Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organization, and the material covers are by no means an exhaustive list of what can come up in your exam, and are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on polymyositis under the section of rheumatology. So, what is polymyositis? It's an idiopathic inflammatory myositis, and it causes symmetrical proximal muscle weakness, which usually happen over a period of weeks to months. As is for epidemiology, it has an estimated incidence of about 2 per 100,000. It has a peak of incidence of around the age of 50 to 60 and has a 2 to 1 of female to male ratio. It is more common in African American and Black population. So as it's for clinical feature, the cardinal feature is a symmetrical proximal muscle weakness, which happen over a period of weeks to months. Occasionally, it can happen at a faster speed, and it would normally involve neck, shoulders, trunk, hips, and thighs. Lower limb muscles are frequently more symptomatic at first than upper limb muscles, and myalgia, which is actually one of the commonest features that's happen in about 50% of cases, can mimic your presentation of PMR or polymyalgia rheumatica. So it would be a reasonable differential to think about in your PACES exam. And it can overlap with other connective tissue diseases such as systemic lupus erythematosus or scleroderma, and it could present as a mixed connective tissue disease. If you want to find out more about a mixed connective tissue disease, please refer to our specific lecture on that topic. As for its other clinical features, you could very frequently see arthralgia, which is quite a common presenting complaint in rheumatological cases. It could present as interstitial lung disease, and approximately it's quite a wide range of numbers that's been stated, but about 20 to 80%, depending on the population that's been studied, of patients with polymyositis have got ILD. It could have cardiac involvement. It could potentially present as a malignancy, however, it's rarer than your other symptoms such as ILD and arthralgia. And it could potentially present as dysphagia with GI involvement. So, what investigations would you want to do in somebody who you think or suspect a diagnosis of polymyositis? The usual would be to start in a systematic order, starting from your blood test. You would want your inflammatory markers such as CRP and ESR. And ESR is usually elevated in about half of the patients. And then you really want to get to your elevated serum muscle enzymes. And those are crucially your creatinine kinase or your CK, and also your some of your liver function tests such as AST, ALT, and also you want to be checking your LDH. absolute MRCP favorite are your myositis-specific antibodies, and those are your anti-Jo1 antibody, which is specific to polymyositis, as well as your anti-SRP antibody, which are frequently encountered in your written examinations. Really, what you want to do eventually is to get a muscle biopsy for confirmation of your diagnosis. In a case of polymyositis, you would be looking at intravesicular inflammation and fibronecrosis, and your EMG or electromyography is frequently abnormal in about 90% of cases. You could also look for muscle edema, which frequently is done on the thighs via the means of an MRI scan. In terms of its prognosis, unfortunately, it's one of those conditions that has got still quite a high morbidity and mortality, and that's why it's quite important to have a thorough examination and history taking in patients who are presenting to your medical take with quite non-specific, generally unwell weakness symptoms. And importantly, muscle strength and function can change slowly with treatment and disease progression, and patients at higher end of age normally do worse because they would have normally cardio, pulmonary, or bulbar involvement as a result of their polymyositis. Management of polymyositis is really quite specialist, and you certainly would want your rheumatologist to be involved in the case. However, the mainstay of treatment is with corticosteroid, which actually about 90% of cases would at least partially respond to steroid. Then you would be thinking about other agents such as your disease modifying drugs like azathioprine or methotrexate, and then there are other options such as IVIG or cyclophosphamide and rituximab for refractory cases. It would be important to note that, especially in your PACES examination, if they ask you about the management, like any other chronic disease in the UK, the management is going to be through the means of an MDT or your multidisciplinary team. And you certainly would want to involve your physiotherapist and occupational therapist in these patients for the purpose of exercises to help with fatigue and muscle strength. As I briefly mentioned before, one of the biggest mistakes that you could make, both in your exams and also in real life, really is to try to mistake a diagnosis of polymyositis for its potential mimics. Polymyositis could have many different mimics. Some of the most commonly encountered ones would be drug-induced myopathy, weakness or cramp due to diet change or exercise, muscular dystrophies, and other neurological disease such as strokes, for instance. So it would be really important to focus on your clinical history and your examinations to try to really nail the diagnosis. Let's do some questions. Question 1 is: a 40-year-old lady presents with 3 months history of progressive symmetrical muscle weakness affecting her upper arms and thighs. She attends clinic in a wheelchair as she finds it increasingly difficult to get out of chairs once seated. She has no rashes, fevers, or weight loss. She has noted some mild shortness of breath, and her CK is 15,000. Which of the following antibodies is most specific for her condition? So right off the bat, you need to be very comfortable with this clinical vignette because it's quite classically describing a case of somebody who could have a diagnosis of myositis. Importantly, they're telling you that she has a very elevated CK that you would not be getting in a case of polymyalgia rheumatica. So really it comes down to knowing your myositis specific antibodies. The options you've got is A, SCL7T, B, ANA, C, anti-CCP, D, anti-Rho, and E, anti-Jo1. And if you were paying attention earlier, you would realize that the correct answer would be option E, which is anti-Jo1. Option A, B, C, and D are all other important autoantibodies in rheumatological diseases and are quite MRCP favorite, and we have discussed all of them in details in our previous videos. Please feel free to go and watch those to refresh your memory. Question 2. A 30-year-old lady is given a new diagnosis of polymyositis after presenting to the rheumatologist with symmetrical proximal muscle weakness and a raised creatinine kinase of 10,000. Which of the following should be given as a first-line treatment? So this is asking you about the treatment of polymyositis. It's already given you the diagnosis, and the options that you've got is A, rituximab, B, corticosteroids, C, ibuprofen, D, hydroxychloroquine, E, adalimumab. And if you recall, you will realize that at least two of these options are used in management of polymyositis, and those are corticosteroids and rituximab. However, we do use corticosteroid as a first-line treatment for this condition, which is what the question is asking you. And in refractory cases only, we will be using rituximab. Thanks for listening to this episode of Bite Size MRCP. If you like the sound of what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss our next episode. Let us know in the comments which topics you would like us to cover in the future. See you in the next episode.